Hi, I'm Mona Firstenow, DD Council member from Vancouver, so south. My question is to all of you. Given our emphasis on employment in this state, how would you, or do you even believe it's possible, to maintain that level that we have, which isn't excellent? It's good. I'm better than most, but it's not excellent. How do we maintain that employment and that emphasis on employment while we implement managed care for health? I have big concerns about that, and I don't understand how that's going to work or how that whole employment piece is going to fit into this whole model of managed care. So if you could just speak to, if your state was where we are and you were looking at this, is it possible? And if so, what would you do?
I think there'll probably be multiple answers to this, but I'll start. If you already have some employment first language in state statute, I would look very closely at how you are going to make sure that that language very clearly applies to managed care. So it may be, if managed care is going to be implemented by a bill, which it was in Wisconsin, which will have to pass the legislature, you could look at building in some employment first language into that, or at least have a very clear cross-reference to your employment first language somewhere else in statute. I also think that you ought to think very closely about what are the contractual obligations that managed care organizations will be subject to with regard to people who already have real jobs. Like, would there be any justification for removing that person's employment supports and taking them off that job and putting them somewhere else? Well, my hope is that there would be very few, if any, circumstances under which that would be justifiable. And certainly saving a few bucks in terms of the cost of services shouldn't be a justification for that. The other thing is we now have examples, in Oregon is one where the governor's executive order actually talks about no new admissions to sheltered workshops as of July 2015. I don't know whether the political climate in Washington would allow that possibility, but if you are going to explore it, now might be an interesting time because you're turning your whole system into something different. Maybe that's something that could be built in. You'd have to see whether there's some legislators that would be willing to consider that.
I have a couple of suggestions and a couple of maybe cautions for you. And these are more mechanics. One of the things that you want to think about is making sure that in a managed care environment, everything is driven off of encounters. Okay, they'll report encounters for the services that they deliver. You want to make sure that you have a good idea of what encounter codes you would want to use that would reflect your values of supported employment. So these are HCPCS codes, and I'm sure that you have state partners that'll help you with that, but you want to make sure that those are services that they can report and that are going to get folded into their rates, all right? Some of the pieces of supported employment or customized employment that don't typically lend themselves to encounter coding, and you're going to have to think this through, so this is like a caution. There's job developers. They don't tend to be people who are doing face-to-face contact with the individual to support them on the job, but they're out there to try to help develop the opportunities. Look to maybe think about ways to support that within the way you write things up. The other thing with regard to what Lynn just said is you can build incentives into contracts and have expectations for benchmarks, and then you incentivize as people do well or do better in order to try to purchase those things that you value. And I will make an observation. The way we closed our state institutions was we shut the front door. That's the first step. If you want to move away from something, you have to shut the front door. There's a lot of pushback for lack of a better word, because there's bricks and mortars, there's employees, there's structure around whether it's an institution that the state operates, so we could shut that front door, or whether these are private enterprises, and you walk a fine line as a state agency, unless you can follow the path that Lynn has laid out, which means you need to mandate it in a way other than for a state to say, we're not going to buy that service anymore, because then you're conflicting with the right of people to have a business, and you're saying we're going to shut you down because we're not letting anybody else in. So you have to be careful about that. But if you can figure out a way to shut the front door using Olmstead, that's a great way to accomplish that. By attrition, you can naturally start to move away from those opportunities. But I can tell you, in Michigan, we have a group of families that are adamant that we cannot close those down. They want the full array of opportunities available, and as long as the full array is available, then we can't shut that front door. So those are just a couple of things from my perspective.
I think those are all good points. That there is no doubt in my mind, as somebody managing the managed care system, the more people I could get employed, the more I could sell. They were low users of service. The best example of this is a friend of mine in Utah, who we talked into leaving his group home and his sheltered workshop in St. George, moving to Salt Lake, getting his own apartment. Got a half-time job at Sears, and he's using very little services to this day. People who have jobs are low users of service. That's what managed care wants. It wants people who have those lower demands. So I don't have any problems thinking I can sell employment first as a system objective if I was in that situation again.
I have a question. How do you all serve children that aren't Medicaid eligible?
That are not Medicaid eligible?
Correct. Like in our state, we have a group of children whose families are income is such that they get family support and respite kinds of service. Do you all do that, or do you have to be Medicaid eligible to receive a service?
So this is Wisconsin, and I'm not quite as fluent as I would be on the adult side, but we do have a Katie Beckett waiver, so that would be a part of it. And in Wisconsin, we also have a community options program that's completely state funded. So I talked about the community options program waiver, but we have a totally GPR funded state program that can supplement certain activities or services for families, as you mentioned, and for children. And all 72 of our counties participate in that, and it's written in statute, and it's there. They have certain things they have to comply with through my section, and so that is another way to supplement those areas.
We also have 3 Medicaid waivers for children, one for children with developmental disabilities, one for children with physical disabilities, one for children with emotional disabilities. And there's 2 criteria. Obviously, there's a functional eligibility screen, and there's financial eligibility. And when you were talking about, families who are making too much money, well, in Wisconsin, we have parent cost sharing, sliding scale based on family income. So if your child is functionally eligible for one of these children's waivers, you could have family income of $150,000 and still get services. You would be paying a parent cost share, but it would be less than paying out of pocket for these services as strictly private pay.
So then the other great benefit of that portion of programming is that the money that's put into that parental fee that we call it, the parental cost share, we put that right back into long-term care supports for children. And so we're looking at, instead of using that COP state money to fund things like a van modification or a home modification, a remodel of a bathroom that costs $40,000, we're going to use that parental fee money and bring it right back into the system.
that's kind of cool. So in Michigan, when Camille referenced the Katie Beckett waiver, do you guys all know what that is? So in essence, it's ability to waive the deeming of parental income and count that child as a family of one because of their needs. So we also have those types of waivers in Michigan. We have one for children with intellectual and developmental disability, and we have one for children who have a serious emotional disturbance. The challenge that we have with those is they're very, very tiny. So, for example, our children's waiver for kids with IDD is about 470. That does have a waiting list. That would have, but that's a fee-for-service program that is outside of our managed care. So our managed care system only covers up to 100% of the federal poverty level. Now, there is the ability within managed care to move up to 300%. And your state may choose to do that, where they'll have you can have spousal contributions and that kind of thing. But we did not choose in Michigan to do that. So we have very tiny service arrays that are available for families that don't get into one of these children's waivers, and that's through general funds. And you guys all know what happens to general funds, right? So we can offer a little bit of respite sometimes, but not nearly enough.
The other way that we deal with that is we do have through the state legislator a legislative action of Michigan was the first state to do cash subsidies to families, and it's for specific population, subpopulation of kids, and families can it's a pretty middle income wage that still earns them up to a certain level for kids with under the educational categories of autism. But they need to be in a center-based program, which is not in keeping with the community-based there. So it's a sense of very much controversy there. Kids that have an SXI level, which would be severely multiply impaired, and then severely mentally impaired. These are not my language, please forgive me, but it's a cash amount, and it can cover some respite, it can cover some camp, it can cover some uncovered expenses otherwise. Those two, that and respite, even the little bit of respite, are still the things that have, and the state's been doing a quality and customer satisfaction for decades on those two programs, and still at the highest rate. And they are the most cost-efficient uses of public dollars. But again, they're tied to a legislative action and legislative budget intake, and so those are challenging. So they're recalculated every year. So.
Arizona has the income disregard feature in its system too, and that works down to about age 3. But you recall I mentioned that there's an access administered risk of institutionalization test that they have to go through at Access before they come to us as Medicaid eligible. And strangely enough, it seems to chop off most kids who are younger than 3. So there is a pot of IDEA money that's utilized by the system, and we had a state pot of money up until about 2007, 2008, and that's been scraped dry. I think it's a group of kids that kind of hangs there in the Arizona system until they hit age 3, and then everything kicks in. And
Thank you.
So in kind of doing an evaluation of all 3 states, first of all, we'll take the FMAP from any of you that you have, because you all have a better FMAP than Washington State has. And we could do a lot with that money. But I think that probably the Michigan model we have some parallels in what we did with mental health, and some of the same problems that you talked about, because we have tried to downsize the number of RSNs, or regional support networks, that we've had. But and part of the problem that Wisconsin has of having the whatever you call legacy counties, that was the same problem we were having with RSNs before we put it out to bid the last time, was that there was a total difference in what the care was living in one area of the state and another, and that doesn't work. So on I guess Michigan specifically, where you have the long-term care also in it, right? It's not just the DD population. You're doing.
Let me answer that very quickly, because then that might help guide the
Okay.
rest of the questions. The system that we presented today is our behavioral health and developmental disability
Okay.
and substance use managed care. We have long-term care also for people who are like aging and disabled. We have a C waiver, a 1915 C waiver. It's called the My Choice waiver. Just went to managed care. I expect the approval any day from CMS. And so it's a separate system. It's going to get folded up underneath that integrated care project, the dual eligible project that we're working on. But this that we presented today does not include the aging and disabled. It's only the Medicaid eligibles. But we do keep folks within that for their whole lifespan. So we have the oldest person on my HAB waiver is 101 in October. So next month she's 101. So, they will stay with us through, birth to death. Yeah.
But so then, are any of you folding in some of the basically doing one managed care model where you're going to have the acute care, your human services?
In Wisconsin, the partnership
program.
And you
That-
probably don't remember that map, but the partnership program is only available in some of the counties, probably like maybe a fourth of the counties. And that actually has a higher capitated rate because it includes the person's, all their long-term support services plus primary and acute care. So, you could have cancer treatment, you could have kidney dialysis, you could have a lot of stuff that's going to have to be paid for out of that rate. And in Wisconsin, in the counties where it's available, it's generally been viewed as a program which makes a lot of sense for people who have complex medical needs or chronic conditions, because you have much more access to a nurse. In effect, your nurse is really sort of your lead, it's sort of the captain of your interdisciplinary team. So there's a lot more attention paid to prevention issues. If you're in the hospital, there's members of the team coming to visit you there to help you get out as soon as possible. So it's not necessarily presented as something that everybody would benefit from, and partly it's pricey.
Mm-hmm. So it's an optional that people can opt in.
Right.
It's like, are they duals too?
You mean
Dual eligibles? Can
with
they?
mental illness?
Well, Medicare, Medicaid.
Yes, it includes that. Yeah. So, right, and I think just about every county where the partnership program is available, the family care program is also available, and there's more people in the family care program than in the partnership program. So it's relatively small because of that.
So we probably want to see those contracts, right?
Right behind you.
Hi. So I have a question that actually kind of builds off that one. In Washington, in 2 counties, as Chris and Nathan said, starting next year, there will be a financially integrated benefit essentially provided through a health plan, either Regents or United, in these 2 counties. And there's a lot of discussion right now happening between advocates and the state about how do we make sure that as these services are turned over to the health plan, that we maintain the good things about our system and make sure that the plans actually meet the needs of the people enrolled. And I should mention that people with developmental disabilities are initially carved out. But there is a question about whether they would be included moving forward. But there are people with long-term services and supports needs included in the first round. So the question that I had was thinking about how this changing role for the state in certain settings, how does the state best hold plans accountable? Is it through one option is like performance metrics and financial withholds. Another option is like contract monitoring. There's also the option of statutory protections, which was mentioned. And I was just wondering if you could speak a little bit about kind of what are the ways that that states or consumers can make sure that health plans are really meeting their needs. What's your advice for Washington as this is set up?
So is a health plan kind of like an HMO?
Yeah.
Okay, all the things you mentioned are relevant. Statutory protections, accountability, all that stuff. But you know what? One of the things that I and a lot of us forgot in Wisconsin is there's really no substitute for programmatic knowledge and knowledge of the population. And one of the things that when family care was starting, we focused somewhat on statutory language. We should have focused more. We focused on contract language. What we didn't really focus on is who are the MCOs going to hire and are they going to hire anybody that knows anything about people with developmental disabilities? And we've gotten so used to the county system, which, there were good counties and not so good counties, but one of the things about the counties is they almost all had some experienced developmental disabilities case managers and people that really understood some stuff. And one of the things that makes me nervous about HMOs being responsible for where people live and helping them get jobs and helping address behavioral issues is I'm skeptical that on day one they will have the knowledge base to do that. And I get worried that without that knowledge base, there could be some people who could end up in institutions or end up in jail or some pretty awful things could happen. And one of the things I think you need to think about is how would you assure that these HMOs have the knowledge sufficient to actually be in charge of coordinating services for people's lives?
Exactly. Yes. Everything that you said is necessary. And because I wasn't in Wisconsin when family care was being developed, I'll take it to that foster care medical home example that I'm directly involved in implementing. And in this situation, you have a number of counties in a pilot area in Wisconsin wherein all children entering foster care and then eventually all children in foster care in those counties will receive integrated health care. They'll get their behavioral health care, their primary, their acute, their dental, all of it from one provider or one integrated health system. And the reason I'm bringing this up, it's not really apples and oranges, and here's why. What we've realized most of all is that it really took having the child protection social service group sit down right at the table with the doctors and nurses and say, well, here's what I need. No, here's what I need. And also having foster parents and maybe now adults, children who used to be foster children, sit at that table. Because if they don't know how to communicate with each other and they don't know what each other needs, it's never going to work. And so if I've learned anything about this type of situation, it's, yes, what Lynn said. You cannot assume that just because a doctor uses trauma-informed care and is a pediatric specialist, you can't be assured that she knows what the child welfare system needs and wants and runs like. And so just having those pure conversations, and believe me, it's not just one. I mean, this has been going on for almost 2 years now, having that conversation. So be ready for the long haul, for lots of meetings, for lots of negotiations, and even some healthy debates and arguments about whose priority is the most important, or how will I advocate for that foster child, knowing that it isn't a perfect system. Some children come into care at 2 o'clock in the morning. So how will the healthcare provider give me that first initial health exam, and how will I communicate with them, and the whole plethora of systems and other issues that come to pass when you're talking about bringing two worlds together like that. I really think that it comes down to face-to-face communication and a lot of work.
Ditto. He said ditto. I just wanted to add another thing that I think is really important that we strive for. We're not as great at it as I'd like to say we should be, but transparency. To the extent that you can require that information is out and available for the public so that they can shop around, if you will. There's some peer pressure that comes to bear because they all want to look the best. And person experience surveys, not satisfaction surveys, experience surveys. How's this actually working for you in your life, kind of thing, but in a way that's transparent so that others can evaluate, where that bar might be. We're moving in that direction. We're not there yet, so don't go look online. You're not going to find it. We have a fingertip report. It's got lots and lots of numbers and data, but it's not easy to read, so we're kind of moving in that direction toward doing a better job of getting it in language that people can understand.
Okay, I see somebody. So this refers to a statement that Lynn made about folks with the highest cost needs may be taking a bigger hit when MCOs are trying to do cost containment. And I wonder if you could expand on the types of hits people experience, and particularly, I'm thinking, what happens, say, somebody who's ventilator dependent, maybe 24 hours, personal assistance service, where the math costs out cheaper in a nursing home than in their own home.
Yeah, interestingly, we had a debate in Wisconsin some years ago about there was an administrative order issued by state government for the so-called home care cap. And the governor at the time and the secretary of the department issued this order saying basically that the state would no longer spend more money on in-home care than they were spending in nursing homes. And ultimately, it was stopped. First of all, there was a lawsuit about, well, wait, you didn't go through rulemaking. This really amounts to a rule. You can't skip over that. But then the other thing that came to light is that when you cost out the individual cost for a man in his own home with a ventilator, you will get a very high number. You cost out the cost of services for 200 nursing home residents. What you've really got going on is a lot of people with a lot of different costs, but they're all smushed together. And the fact that the nurse is going into Mr. Jones' room 5 times as often as Mrs. Smith's room, that's not reflected in higher nursing costs for him. It's just like all the costs for a nursing home averaged together. So there's really a numbers game that makes it look like the cost of everybody in that nursing home is the same, when in fact it's really not. So when that was sort of pointed out to legislators and to the media, people began to realize, well, this isn't really a fair thing. So that was fought off. Now, and just to restate what I said, you would never see an email from a CEO to staff saying, oh, go after those high-cost plans. It wouldn't be that way. It would be like, gee, we all have to tighten our belts. We got to all team up here. We got too much red ink. We got to do better next year. And the case managers would interpret that as meaning, I've got 3 or 4 people on my caseload who are $400 a day or more. I think I'll go take a look at them. So I think that they were sort of deciding on their own that would be a place to look. And of course, you're not going to take somebody's ventilator away, but what people would do is they might look at, let's see, how much care is being provided by the family versus other in-home caregivers. I wonder if we could, ratchet up the family hours and maybe cut down on the paid caregiver hours, which of course means it's basically like, maybe we could just like tighten the screws on the family a little bit more. They would take that sort of form, that kind of stuff. Or maybe there was some money being spent for the person to go out and do activities in the community, and that involved transportation and maybe assistance in the community. Well, maybe we'll take that away. And we'll make sure the person's still safe in their own home. It's just these other community activities, maybe those are kind of a frill. It would be that kind of sort of shaving it down. That's the kind of stuff that we would see. And sometimes we would have to go to hearing to push back and say, no, actually, these are legitimate supports that people needed. They were part of the original assessment. They were part of the plan. There's been no change in the person's condition. There's no legitimate reason to come here now and whack this guy's plan other than you're just trying to cut spending.
I have that discussion on a regular basis, I will tell you. Even in our world, I had a call from an auditor, a state auditor the other day, shocked at the $200,000 cost for one of our folks. And by the time we got done talking, and she asked a lot of questions, and I said, that's per policy. That's absolutely allowable. They're within the constraints of the policy. And by the time we were done, she said, oh. Because, her first answer out of the gate was, it's a lot cheaper to serve this person in a nursing home. And I said, it wouldn't be, because this person has such high medical needs, which is exactly the same thing Lynn just said. But one of the things, to your point about this shifting over to natural supports, we were starting to see some of that. And remember me telling you about those conversations that I have with the ALJs, which apparently is quite unusual. Most state staff don't get an opportunity to interface with their law judges, the tribunal judges, in an informal way. But we were hearing that there were folks going to hearing, if you will, sorry to use that word in the same sentence twice, that they were trying to push it off on natural supports. So we put language in the provider manual that says that yes, you need to look at natural supports as part of this person's, total package, but you cannot mandate that natural supports must be used. So we actually put a sentence into our Medicaid provider manual, and that has gone a long way toward trying to mitigate that concern that you're just going to say, well, they're living with you, you can take that responsibility on, and we'll pull the staff out.
On the medical side, we didn't have that big an issue. We had a vent program that was capitated at $18,000 a month. The issues we had were on the behavioral health side. And what we had in place was what's called a cost effectiveness ceiling. And that was 150% of either the ICFMR cost or the state hospital cost, which triggered not cuts, but intensive reviews by multiple people month after month, because we would find things like somebody needed a one-on-one or a two-on-one, and years later they still needed a one-on-one, or they were being billed for one-on-one or two-on-one, and everybody agreed they no longer needed it. Those kinds of decisions were savings to the system in terms of pulling off the one-on-one. In some cases, we found billing feature problems like everybody in the house got that rate of 150% of the state hospital rate just because the one guy presented a lot of challenges. So once we straightened that out, we got some savings to the state. It was never approached with the point of view of how do we squeeze the system to save dollars. It was a matter of where would we do what people would agree is just good cost containment under the pressure of overall pressures on the system to reduce costs or save money.
From Arizona, I know you spoke about the ABA benefit and the recognition of the value of that. I don't know if the rest of you specifically addressed that, but here in our state, we've really struggled with that. Every insurance company has had to be sued in order to get them to comply and provide that benefit, and we're still not done doing that with all of them yet at this point. And then comes the problem of who's a qualified provider, because there's not a licensure in this state for ABA. There's a national certification and a lot of discussion around that in our state too. What kind of things have you done, at least in Arizona, if not some of the others, to make that workable for the state?
That's a very good question. Arizona got the autism insurance mandate in, I think it was in 2009. But beginning in 2003, 2004, we created a service definition, described intensive in-home behavioral supports. We adopted the national BCBA criteria. BCBA criteria. Thank you. We started building a network of those folks. Sponsored one of the universities to start doing a training program to crank those people out. And what's neat in a managed care program, if you're running the thing, is that you can slowly build services. This year you can have 100 kids in it, and it barely shows up on your financial radar. Next year you can have 200, and you can slowly build with the growth of your program a service like that. And it's several $1 million today with, I think, 100 plus infants and toddlers in it. The insurance mandate, it's going to be interesting to see how that helps or hurts. They're obviously going to have to use the network we'd already developed. I think there was some hope on the other side that would reduce costs on our side, so we wouldn't have to do it anymore, and the acute health care plans would have to do it. But we just went ahead and built it into our services.
And Michigan just in 2012 had both a commercial insurance mandate passed, and also the legislature appropriated $19 million for us to develop a Medicaid program for that, and that was that 1959 state plan amendment that I mentioned earlier, which provides ABA services, applied behavior analysis services for kids on the spectrum between 18 months up to 6 years. And what we did in part recognizing that we were going to have challenges also with that provider network. And this goes across any, I mean, we can talk specifically about autism services, but this goes to any of those services where you're going to have a highly specialized, highly trained individual that's your qualified provider. What we did was we recognized the board certified behavior analyst, that BCBA. It's a national accreditation that they receive. It comes out of Florida. And then in addition to that, we recognized some professionals like psychologists and some master's level social workers who could receive the training and become those board certified behavior analysts. And so we kind of gave a window of about, well, it goes till September the 30th of 2016, hoping that people will, or maybe 15, that people will get that training and become those BCBAs. We have increased our number of BCBAs just by the fact that we now have a way for them to get paid by 100%. We're at 80 now. We were at 40. So they are coming back into our state. Now I know with Washington, you guys did it a little bit differently, and I believe you agreed that it was an EPSDT service, an early periodic screening, diagnostic, and treatment service. So that puts you guys in a whole different world from anybody else in the country, pretty much, to recognize it as an EPSDT service.
Used to have that, and then turned it into a waiver. You want to talk first?
I didn't feel fluent enough. I got
Well,
out
just-
my little cheat sheet, but we have an autism waiver. That serves young children with the autism spectrum disorder. And it's, I believe, a limited number of years with the intention that the intense services will then lead to provision of less intense services in another children's waiver. So it's, I think, of a limit of 3 years, I believe. And so that is currently Wisconsin's perspective on provision of those intense sorts of services. And please do, yes.
The other thing is, there's sort of an interesting irony here about, being so strict about what model and evidence-based, because we've always said, well, supports to family should be family-centered. Well, what happens when some parents say, actually, what I want is a different model? And you got this sort of conflict between evidence-based versus what the parent wants. In Wisconsin, we actually ended up acknowledging a couple other models of service delivery. So it's even more complicated than what you're saying, because then when you've got 2 or 3 models, you've got the certification issue for all 3 of those. And we actually do have a person in state government who is basically in the certification role for all 3 of these kind of programs. So we do have certification. And there's always, contesting, well, I should have been certified. I don't know why I'm not. I'm just as good as the other guy. I mean, that never ends. But the other thing is, we've had a statute now for probably about 5 years requiring insurance companies to cover the cost up to the limit of whatever their coverage is, and then Medicaid kicks in, which most everybody thought was a good idea. And a week ago, I was involved in a focus group with a bunch of providers. And the thing they were telling me is that now, there's such a variety of insurance plans out there that some of the families have these really high deductible, high copayment plans. And if you have 3 visits a week for an intensive autism treatment, and you're paying, like $40 per visit as your copay, that's $120 a week. That's $500 a month. That's $6,000 a year. That's a financial hardship on these families. So I was hearing stories of some families saying we had to stop getting the treatment because we couldn't afford the deductibles and the copay. And yeah, right. So it's interesting now in Wisconsin. People are starting to talk about, how do we deal with the insurance requirement when it's a financial hardship on the families to cover their share of the insurance? Like, do we need to find some other source of funds to cover their their copays, and we obviously haven't figured that out yet.
In our handouts from Michigan, there is I'm sorry. In the handouts from Michigan, we put in descriptions plus a flow chart of the plan. That's not to say that it's there's some at the website of the organization that's managing the implementation. There's some tools for family members to learn about the benefit, which I think is the translation of whatever you create needs to be written in a way that families understand it and it applies in a practical way. So I just give you that as a request on behalf of the family side to say, okay, great legislation. Okay, now put it in a way that makes perfect sense to me so that I don't go through all the steps and then find out that I can't afford the first visit. Okay, so spell it out in a way that actually makes practical sense.
I had a question. I think this is directed at Lynn. I think it was Camille mentioned that in Wisconsin, your Aging and Disability Resource Centers actually do fair hearings. Am I right about that? I thought that's what I heard. And I'm wondering how that worked.
Related, there's a job category in the ADRCs. There's two. One is called Aging Benefits Counselor. The other is Disability Benefits Counselor. The Disability Benefits Counselor provides free benefits counseling for people from age 18 to 65. Over 65 are the aging benefits counselors. If somebody applies for SSI or Medicaid and they're denied, and there's an appeal, and the appeal requires an administrative hearing, these benefits counselors they're not lawyers, but they are trained to go to these hearings. There is a legal backup program that the state funds independently of the ADRCs to provide training and legal backup to all the benefits counselors, because there's a lot of them now. There's probably like 85 disability benefits counselors and maybe 50 aging benefits counselors. So there's a legal backup contract for that. And sometimes in these administrative hearings, if the benefits counselor wants help, or let's say they're fairly new on the job, the legal backup attorney might accompany them. But yeah, it does include that kind of representation. And we actually, I'm not sure this has been documented, but we believe that the percentage of people in Wisconsin who are technically eligible for Medicaid and SSI but not receiving the benefit has gone down because of this program.
And the ADRC program it's been useful for, in your opinion, as an advocate, both for seniors and for people with disabilities. Does it have a?
I think the best thing about it is it's this one-stop source of information. It used to be in the old county system, if you wanted to find out, information about this service or that service, you'd look in the yellow pages, you'd start calling, you have to play phone tag. It'd be really hard to find it. The idea of the ADRC is you can go there and any question about long-term care or benefits, you can get it answered. And you don't have to be Medicaid eligible to go there. So for example, you could be an elderly person who's still got excessive assets to qualify for Medicaid, and you want information on good home care providers that you could purchase private pay, you can get that from the ADRC. So and this is one of these things where consumer satisfaction has been really high for these two.
So I had two questions. The first was around the early intervention and the ABA services. So if you've been doing it for quite a while now, are you seeing a savings then when it comes to the school-based services that are needed once the kiddos get into the elementary school settings?
We started watching that cohort around 2006, 2007, as they were starting to move into the school systems. We were starting to see some savings and some anecdotal stories. That's about the point at which I retired, and I hope somebody continues to watch that group of kids. Because we were betting that it was going to pay big dividends. And
yeah, I think that's a cohort that probably should be watched throughout their lifespan for savings. Then my second question was, I was just curious as you were all talking this morning, and I know one of you no longer has our institutions, and I think that's Michigan, right? But for Arizona and Wisconsin, what size, how many individuals do you still have in your institutions?
Arizona has one public institution left. It has shrunk to about 125 folks. Nobody's been admitted for many years, and it's basically attriting. And we don't worry about it much anymore because it's small enough number, and it's obviously going to go away.
Thank you.
I want to just make one quick comment. Well, actually two. When we were here in the discussion, what we did, we got to a point where we had 141 people left, and it really gets to be cost prohibitive to continue to keep that thing operating. And staff start to feel like, I'm going to lose my job, so they tend to attrit faster than folks would be coming out. So what we did in order to help that process along was we added an additional payment into, remember the Habilitation Supports Waiver was our original C waiver. We added an extra $8,100 a month to their capitation payment to support them in the community, knowing that they were going to be those folks that might need that 2-to-1 to start with, and then that 1-to-1. Our intention was to sunset that, and I haven't seen that sunset yet, even though folks are several years out now and probably not using that 2-to-1 anymore. So they're getting about $13,000 a month to support them. The other point I want to make is something to keep in mind is you can have large public ICFs, and you can also have privately owned ICFs. Michigan has no ICFs, and the only other two states that can say that are Oregon and Alaska, right?
So I'll just say something real quickly about that. Having done the monitoring of those folks still, the money that Deb's talking about, but they haven't sunsetted it, thankfully, please don't today, that they're all redirecting that dollar for one person that was one of the highest need people to her supported employment and reducing the intensity of her behavioral support needs and redirecting the dollars to her more of her community living needs, which is exactly what you would want in the end anyways. The other thing is that Michigan did not send people out of state. And I really want to emphasize that because it was a values thing. They're Michigan citizens. They're staying in Michigan. We have to figure out what our citizens need. The state did another thing is that it I think, I couldn't remember who brought up, maybe it was this morning's discussion about addressing the challenges of the system's infrastructure problems in terms of direct care staff. I think you had brought it up this morning, is that they made an intentional action in making sure that we prepared people to deal with people that had very complex behavioral and medical support needs, and went statewide with creating a culture of gentleness that anyone that worked in the field had access to, not just the people that were going to be supporting people that had left the institution. And that continues forward. And it has made a cultural shift on the role of direct support staff. And let's be honest, the two people and throughout any system that you look in the country that are the most overlooked and under applauded for their work are direct care staff and supports coordination case managers, supports, targeted case managers. Those two folks have the most direct touch, but we don't recognize how valuable their role is, and then also say, we're going to put the same intentional emphasis on your development so that you can sufficiently and with good quality support the people that we're talking about. And that was a really key transition that was part of that closure.
So we have two state developmental disabilities institutions about the size of the one in Arizona. So that's a total of maybe 250 to 300 people. I would say probably 1% or less of them of that group are enrolled in family care. So there's no particular hook for the managed care organizations to go visit them, to know anything about their service needs, to plan for community placement. They're not really on the hook to think about them. The counties are not on the hook because the counties are out of the adult long-term support system, or at least most of them are. We do have some private ICFMRs. That number's come down quite a bit. We used to have a lot. We used to have 5,000 or 6,000 people in those. Now it's down to maybe 1,500. Two of those were religious facilities. St. Coletta's, where Jack Kennedy's sister was, and Bethesda. Both of those agencies have decided to shut down their big institutions. When you're talking about you don't send people out, well, a lot of people were sent to St. Coletta's and Bethesda from all over the country. Catholic families who wanted a good Catholic home for their person with a developmental disability would send them to Wisconsin. So of course, they then become Wisconsin's responsibility to find community placements for them.
One other quick thing, though, is that even though there's no incentive, for example, for MCOs to go visit those particular institutions, we're trying to, on the outside of that, build incentives for counties and MCOs to do that. And I'll quickly mention that we've implemented something called the Connections to Community Living Initiative through the Money Follows the Person program, wherein we took MFP administrative dollars to hire on the ground, boots on the ground folks, not to take the place of what the Aging and Disability Resource Centers do by providing options counseling, but actually looking at, well, for nursing homes, the MDSQ data, or for our institutions, just kind of a file review of who wants to get out or who wants to move to the community. And we utilize those boots on the ground people to start the process, to look at what barriers those particular individuals might have. And so we're pretty new with this program. I only got it really going on the ground just this February, but we'd love to keep you updated about it. You can go to our Department of Health Services website to find updated data about how we're effectuating transitions to the community, and they don't just have to be MFP. But what we also did, though, to add to that, is that in regards to MCOs, we implemented an incentive program. So $1,000 per successful transition to the community. Now, that hasn't been so popular with the nursing home industry, for example, and we don't use it, obviously, to say, oh, just move whoever can move. It's a meaningful process. It's not an event, but we do build in those types of incentives because, of course, if you know anything about MFP, really the increased FMAP just goes right back into the state GPR. So most managed care organizations technically see no benefit to doing it. It does benefit the state. We put the money right back into transitions to the community and long-term support, but we figured we could possibly increase our chances at more increased FMAP if we provided an incentive. So
I'd like to thank the panelists from each of their states, Michigan, Wisconsin, and Arizona. I'd like to take the time to acknowledge our legislators, that came this morning, and possibly their aides that are still in the room. And Evelyn Perez, thank you for taking the time out of your busy schedule to join us. Thank you, Ed, as Executive Director, for putting this together, along with your colleagues, David Maltman, Donna Patrick, and collaborative Sue Elliott from the Washington State ARC. It's been a very informative afternoon, and hopefully we can continue it rolling tomorrow. Thank you.